Very good evening for today, my beloved colleagues. As we have commitment to talk on ECG, actually, we had long days before, basic ECG, different types. We divided into 4 headlines before. Those who attended, you can remember it. But today, regarding the ECG will be a very different one, a little extraordinary things. And I believe that possibly you may not have seen or may not have heard also about the informations today, what will be discussed. So even then, why actually we have chosen it? The observation is in the recent exams, in the clinical exams, they have selected some ECGs not directly related with the heart diseases. But clinical situations are very common. For that, we took decision to discuss some ECG issues, which will be useful for your exam as well as in your day-to-day life experiences. Sometime, if you are working in outpatient department or even in the indoor, you may face the patients of electrolyte disturbances. But if you send the lab test, usually lab gives the report after few hours. Sometimes these few hours will be very golden time, and sometimes it will be very risky time. But if you know the ECG changes, very severe electrolyte disturbance, by looking at the ECG, usually ECG machine is available in your hand, especially in the indoor setup. So immediately within few minutes, you can see the ECG. And if you can correlate your knowledge of ECG changes with electrolyte, especially electrolyte I am meaning, then you can take immediate decision to save a life. You will understand today. But today we actually encompass some other disease clinical situations as well, not only the electrolyte disturbance. With these few words, inviting all of you today to today's sessions with our institute as such, you know. So our topic is set up like this: ECG changes in non-cardiac issues. Again, I feel better, and I hope you will feel better also. Someone written ECG general. Yeah, before there was a ECG in general and broad headlines, 4 headlines. I can come to conclusion later, Dr. Ramisa, possibly you asked about. Anyway, so as the ECG changes in the non-cardiac issue, today what will be discussed, we will not discuss the very basic thing. The belief in my mind is that you know something about the basic things of ECG. For that, today's discussion will be a little bit advanced discussion. Even then, if you need any further discussion, any question, you can raise the hand. So let's go on. Before that, just one by one, Dr. Ashraf, even you have the echo, don't mind. Can you tell me what ECG you have seen of non-cardiac issues in your life? Can you remember any issues? The ECG showing some features, it is not heart disease, directly heart disease. Can anyone give any experience, any informations? Dr. Ashraf?
Pulmonary embolism.
Have you seen embolism ECG in your clinical practice? That means in your training time as well?
No, sir. If ECG cannot detect, and clinically we found
Yes.
suspect
You have seen,
pulmonary.
yes, pulmonary embolism you have seen the patient, but you have not seen ECG. Yes, it is true. Sometimes pulmonary embolism ECG is not very obvious. Okay. Dr. Nasir Ali Khan, what is your experience of ECG other than cardiac disease?
Sir, panic attack, ECG patient,
Seems to be any
yani
changes? Can you
tachycardia.
remember? Tachycardia, that means sinus tachycardia.
Yeah.
Yes, doctor, thank you. Though I didn't include it today. You are right. Sometimes anxiety can cause sinus tachycardia. This is also one ECG change, very, very minor changes. Any other one can share, please? You have seen ECG in your life, but it is not due to cardiac disease. Haven't you seen any electrolyte problem? Anyone, please? In the ECG, electrolyte disturbance. Possibly you have seen, but you cannot remember.
Hypokalemia, sir.
Hypokalemia, right. It's very important electrolyte problem. Hypokalemia, very right. So anyway, let's go. This is the normal ECG, just for recapitulation. Look at different heights and widths of different parts of ECG. That means the wave segments, intervals are there. And it is true that the 12 appearance of 12 lead ECG are of 12 types, not same to each other. And very gross difference is in the AVR. All the waves are down. All the waves are down. So if anything is up, rather this is abnormal here. If suppose the wave is positive, any wave is positive, it will be abnormal here. And this is the message we discussed before in general discussion, that is a reciprocity. I will not ask you, just I'm telling, you can recapitulate. If you attended before, you can remember. Reciprocity, what I like to mean, in the position of the lead, suppose in the left-sided lead, have the appearances which are opposite to the right-sided lead. Even in normal ECG also. For example, if you compare the VR, that is the right-sided lead, with any one from the left. Suppose lead 1, or even AVL, rather better lead 1 or V1, right? V1, V2, V3, right? These are the left-sided, especially V5, V6. If you compare with the VR and the V6, you see the maximum in the left-sided leads are having more positive deflection. But in the VR, negative deflection. If anything wrong happened there in this arrangement, this is abnormal. And very classic example of the ST segment when we diagnose myocardial infarction. ST segment elevation in one territory of the heart, that is one arterial territory. In opposite surface, the ECG will have ST depression. This is called the mirror effect also. So this is called the reciprocity. Anyway, we will not discuss too much, and the topics of discussion we hope today like this. From there, we will try to show you. You see, these are almost common. Drug effect also common. Some drugs commonly we are using, but the ECG appearances are not common. It is also true. Let's see now one by one. So this is basically extreme right axis deviation. Extreme right axis deviation. The key feature is here. You see, though it is not indicated, you see the P is inverted here in the lead 1. P inverted. Okay. And QRS is down. So down means it is opposite, usually opposite to our expectation. And Dr. Nasir, can you see the AVR? What is the appearance of leads in the AVR? Is that the positive deflection or negative deflection in the AVR? This is the AVR.
Yes,
Is it positive? Is that positive? Yes. Yes,
yes,
right? It's a
Yes,
positive.
sir.
So
yeah,
just before I said reciprocity, in the left-sided lead, this is negative deflection. In the right-sided lead, this is positive deflection. Which one is normal? Is lead 1 is normal? Dr. Nasir, if possible, can you be connected with me? Is the lead one normal? Dr. Rafia, is the lead normal one? Is the lead one normal?
No, sir.
No. AVR normal?
No, sir.
No. Why not normal?
Because the normal
Because in the
picture was
AVR,
Is always
always down,
downward.
always downward, always negative. Okay? Always negative. That
Yes,
means the
sir.
predominant waves will be negative in the AVR, and the one, that means the left-sided lead, it will be the positive. So both are abnormal, opposite to each other. Okay? So
Yes.
there are some other explanation how to say extreme right axis deviation. You have to go through our previous ECG link. In this extreme right axis deviation, what may be the reason of this? But one can think that if it is the dextrocardia, it can happen. Heart is turned to the right. So the right-sided lead showing positive deflection and left-sided lead showing negative deflection. But is it dextrocardia? If you can answer this question, you will understand the answer also. Is it dextrocardia? To get the answer, in the dextrocardia, all the right-sided lead will have positive deflection comparatively. There is a comparison always. So if you check the limb lead, you can see right-sided lead have positive deflection. If you come to the anterior chest lead, that is in the chest lead, not in the limb lead. What are the chest leads? V1 up to V6. So what is the normal appearance in the chest lead normally? V1 R wave will be small, it will be increasing, and up to 4, 5, it will be the tallest, or up to 6 at best. Is the arrangement the same here, Dr. Rafida? That means lead 5, 4, 6 having tall R, then the R in the V1, V2. Did you get my question, Dr. Rafia? You see, these are R, 4,
sir.
5. So these are taller than R in the V1 and V2. It is okay? It is true?
Yes, sir.
It is called the progression of R wave. Naturally, progression of R wave. It is true. So this is normal. Though our limb lead is showing right-oriented ECG. That means the predominance of right-sided electricity. But chest lead showing no. So it is not dextrocardia. Okay, Dr. Rafia.
Yes, sir.
So now what could be else? Only limb lead is showing the changes, the opposite, reciprocity rather to say. But chest lead is not showing. Can it happen that who has done the ECG wrongly placed the ECG? That is the left in the right, right in the left hand? Can it happen?
Maybe.
Yes, it can happen. So this is the wrong lead placement. Commonly, the left lead is fixed with the right, right lead is fixed with the left. By nature, it happens throughout the world, usually by the nurses which are engaged or on duty to do the ECG. So this is that one. But the clinical significance of this, in this ECG, if otherwise normal other than the axis deviation, actually patient does not have any disease. But by looking there, you may be confused with very, very deep Q wave here, right? If it is a very gross Q wave, it will be pathological Q. You can think that it is myocardial infarction ECG. For that, it is very important in our day-to-day ECG. Any question in your mind here? No more. Okay. So now look at the next ECG. What you are looking, Dr. Rafia? Look at everyone. Suddenly you see that P is down.
Down.
And this is downward deflection is more. Actually, it will be the S. In our basic ECG information, it is S. Very deep S. But it is not normal here. Is it normal? No.
No.
No. So if it is as such, look at the AVR. What is about in AVR?
If we are upwards,
So these are visible R and R is tall, which is abnormal. So these are opposite to each other. Okay.
yes.
For that,
Yes.
it is called the right axis deviation and extreme right axis deviation. Extreme right axis deviation because AVR is positive here. Now, one possibility is this is wrong lead placement. Another possibility is dextrocardia. So now scrutinize, is it dextrocardia? It means you have to check the chest lead. Look at the chest lead. Is there progression of R wave? V1, V2, V3, V4, V5, V6. Look at R is increasingly taller.
No.
No. If it is no, that means all the leads are arranged in the right side. What is the diagnosis now?
Dextrocardia.
Yes, this is dextrocardia. Thank you very much. Now come here. This is the typical appearance of ECG in the pericarditis. Why we should know about pericarditis? ECG changes of pericarditis. To compare which dangerous disease? Pericarditis is not dangerous disease in general, but other disease which confuses us that is it pericarditis or what else? Especially if there is ST elevation. Please try to remember a very common thing we are discussing. If in the ECG, ST elevation is there. So commonly what we think in the ECG in the cardiac disease? We think myocardial infarction.
Myocardial infarction.
Does myocardial infarction patient have chest pain?
Yes.
Yes.
Obviously.
Does pericarditis patient have chest pain? Yes. So chest pain there, ST elevation there. So definitely it will be challenging for us that it is myocardial infarction or pericarditis. For that, we need to learn pericarditis well. What is the ECG changes in pericarditis? So look at now. There are different stages of ECG changes in pericarditis. You see, stage 1, 2, 3. That is the first appearance is there. First one. Usually we know more about this type of ECG, ST elevation. Sometimes we say chair-shaped ECG. And this is a diagrammatic representation to make you better for a better understanding. So generalized ST segment elevation. Another one may be new word to you. This is called PR depression. Dr. Rafia, have you heard PR depression? You have heard ST depression, but have you heard PR depression?
No. No, sir.
No. So this is new word maybe for you, some of you. PR, you see P to R. This is below the baseline. This is below the baseline. Actually, how to make the baseline? It's not easy to show you here. The baseline will be the T and P wave, T of the previous lead and P of the subsequent lead. If you make a line, it is the baseline. So this is the baseline here, actually to draw, but I can draw in another complete ECG picture. Anyway, so this is, if you think from here, you see, is it depression or not?
Depression.
Yes, depression. Sorry, why I cannot remove? Yes. So this is the P. PR depression is very characteristic in the pericarditis. Now, subsequently, time will go and there is a changes, you see. Transitional period. It may not be stable for a long time. J points. What is the J point? J points on the baseline. That means J point will be in the baseline. Which is J point? Can anyone say what is J point? Sorry, if you cannot talk, I think that you know, so very difficult to continue. J point is here. Here. I'm drawing again. Junction of the here you see. This point is the J point. It is called J point elevation. S wave and the ST segment. It is called the J point. QRS already, you know, QRS. So junction of the QRS and the ST segment. This is the junction point. This point may be up, may be down. So in the acute pericarditis, you see the J point is up. But here, J point became down to the baseline. Clear now, Dr. Rafia? This is the J point. So it is along the baseline. One, it is a transitional. Before T wave begin to flat, T wave begin to flat. T wave will begin flat later. Okay, this is the T wave a little picked up a little, but here T wave becoming flat in the later part. Now come to the next one. T wave become down. So from up, flat, down. It means, I like to say you, in acute pericarditis, a little later, you may not get the typical picture of a stage 1. You may get this one also. Only T wave down. So a T wave down may happen in the myocardial infarction. In this time, we have to be very cautious about to say it is myocardial infarction or not. Okay, a last stage is the normal. But if you get the typical stage 1, we can say, yes, it is more likely to be pericarditis. But it may happen, there may be associated myocarditis and other heart muscle damage, and you may get the troponin I. So heart muscle damage does not mean coronary artery disease also. But muscle damage can happen. Now a tricky question to you. If there is ST segment elevation, it is written as generalized ST segment elevation. What is the meaning of generalized? And somewhere it is written as diffuse ST segment. Maybe in the down you see diffuse here, diffuse ST segment elevation. What is the meaning of generalized or diffuse? It is the meaning the same. Can anybody say?
All leads, sir.
Almost all leads. Not 100% all. Sometimes some lead may not show pictures. Almost all leads, actually to differentiate from the territorial distribution of the lead in coronary artery disease. Suppose in the inferior lead, the change will happen in 2-3 AVF. It is territorial lead according to the coronary artery. But if it is a pericarditis, it will not maintain the territory 2-3 AVF. ST elevation may be in the 2, 3 ABF plus there will be ST changes. That means ST elevation in other lead as well. We cannot make a calculation that that coronary artery is involved. It explain the word actually generalized or diffuse ST changes. Here ST elevation. I think things are clear a little to you. If Dr. Rafia says the yes, then I think all of you already know about Dr. Rafia.
Yes, sir.
Okay. Thanking you. Where is the brush? Let's see. Maybe brush. I got the brush. Yes. Just removing it for you. Give me a few seconds. Otherwise, the marking will disturb. Sorry. Right. Okay. Now come to. If you want, doctor, you can make a snapshot also. It's a very good ECGs are there. I think explaining nicely also. Rather better than my talk also. It is written there. Huh? So again, to repeat the features of acute pericarditis. You see diffuse ST elevation, and there is actually J point elevation as well. And PR depression, you can identify there. PR depression, not visible in the all leads. In this lead, you see down, lead 2. Lead 2. Actually, we need to identify the baseline. Otherwise, how can we say elevated or depressed? So this is the TP segment. Now I like to show you TP segment. Which will be the TP segment? Let's go to a very nice ECG for better understanding. TP, TP. P here, you see T. Yes, if I draw a TP segment, that means it's taking time to explain everything. This is the T. Can you see the T here?
Yes, sir.
This is the T. If I draw a line for the T like that, and again from the P, from here. So T of the previous lead and P of the subsequent lead. If you connect there, it will be the isoelectric line. From there, if you compare, if it is a line go like that, so where is the PR? PR down or up or isoelectric? Dr. Rafia?
Downwards, sir.
Down, really down. So to compare the down or up, we have to make a isoelectric line here. So come now in the lead 2. You see T is above, P is down. If you make a line, it will obliquely go up, right? Obliquely go up. So this is the PR. This is the PR. Very critical to understand this isoelectric line. So this PR is down. PR is down. Okay. PR is down.
Isoelectric line is
Isoelectric line, you have to connect the T of the one lead and P of the next lead. P of the next lead. This is the T and P. This is the point of T, this is the point of P. You just make a straight line. This will be the isoelectric line here. Here. That means the whole lead. This is the, you see, this is the lead 2, right? It is not the different lead. Same lead, I am telling about the complex. Sorry, if I say lead, maybe I was wrong. In the QRS complex, right? Each one is a complex. So one complex with the subsequent complex. You not that 2 and 3 connecting. We are connecting one lead in the same lead, subsequent ECG complex from there. Clear now, Rafia?
yes, sir.
Okay. So this is PR depression and ST elevation. Very basic. There may be additional other features. Okay. And it will be the diffuse ST elevation, not according to the coronary artery territory. That's all for the basic of ECG in acute pericarditis. There is some other clinical feature. Again, the pericarditis ECG, you will get it. PR depression, you see T is much above. Okay, ST elevation also there. Another word is the J point elevation. Right. Oh, this, sorry, again, we need to remove this. Any change here? Again, you see PR depression, ST elevation and diffuse in many leads are there. So this is again acute pericarditis. So I have shown more ECG for your understanding, and common ECGs these are for that. Now come to other issues. A patient of a stroke. Why a stroke? We are discussing ECG of a stroke. Suppose a patient have infarction, cerebral infarction. Can the same patient have cardiac infarction? Who will answer? Just clinical question. A patient have ischemic brain disease. Can this same patient have ischemic heart disease?
Yes.
Yes. Basic thing are same. Predisposing factors also same. Risk factors also same. So, a patient have the stroke, we are going for CT scan to see the effect of ischemia or infarction. Similarly, if I want to exclude any cardiac disease, patient may have or may not have, both possible. If I see that this type of ECG in the patient, same patient, that is a stroke patient, immediately I can think, yes, this patient has ischemia in the heart as well. Right? Doctor?
Yes, sir.
And this patient may have infarction as well. So we will further investigate cardiac issues, echocardiogram, troponin I, okay, minimum 2. And interestingly, we may find no changes in the heart, only ECG changes. Can we say that heart is in trouble even then? No, no, because this type of ECG change can happen in stroke patient also, the brain ischemia also. Okay. So in the bottom line is, in stroke patient, if this type of change happen, that means the T inversion in the V2, V3, you see, lead 1, 2, only the AVR is different. You see, AVR always, when these are down, AVR will be up. It is a reciprocal change. So in a stroke patient, inverted T wave can say two information. One is, it is change associated with cardiac ischemia, or it is changed only in the stroke. Heart is normal. So we if possible, if we can remember these changes, we can say that heart may be normal also by looking this type of ECG. It is a change happening in the stroke patient. Okay. Please try to understand. I told you today's discussion actually a little advanced, not very basic. You see, this is the acute ischemic stroke, and you got the ECG changes. Diffuse T wave inversion. Diffuse T wave inversion. And diffuse T wave inversion, another disease also you can see in the heart condition. It is called hypertrophic cardiomyopathy. But if you cannot get in the echocardiogram hypertrophy of the heart muscle, but you may get this change in a stroke patient. So this is the difference. Okay, now come to drug issues. Though digoxins are not used too much, but academically this is very important. Lead 12 lead are shown here, and each lead, what the changes are there. So all lead may not show the typical changes, remember, for any clinical situations. In the digoxin issue, we have to say two words. One is the digoxin effect, another is digoxin toxicity. In both conditions, there is ECG change. The typical ECG change, look at it is called the reverse tick mark or check mark. Reverse tick. Look at the ST segment. This is down. So this is the reverse tick. Can you understand reverse tick here, Dr. Rafia? Reverse tick.
Again, please.
Reverse tick, how can I draw? Doctor. Reverse tick. This is not reverse tick. It is a normal tick. Reverse tick is reverse.
Yes,
It is
sir.
down.
Yes,
This is a
sir.
small. This is a small. This one the reverse. So you just compare there. This one, this one. This one. It is reverse tick. And look at the T wave as well. T wave is up. Right? In the V4,
Yes.
T wave is up. But in the V5, T wave up or in the baseline?
Baseline.
Baseline. I will show you the next slide now. Sorry. This color, this change, it's disturbing. This digoxin effect, very academically important, interesting. Reverse check or reverse tick. This is the reverse tick. Reverse tick. So this is the T wave, more likely to be isoelectric. More likely to be isoelectric. Now come to the next one. Grossly compare. There is a reverse tick, but T wave is down here. Clear now? In the
Yes,
C
sir.
picture, T wave is down here. So wherever the T is down, it is grossly indicating toxicity. Whenever the T is isoelectric, it is digitalis toxicity. When the T is above, it is digoxin effect. It is not toxicity. You can make the snapshot of this picture. Very easy to understand. By look at the ECG appearance. If reverse tick, that means the ST segment depression is there, with T wave is above the baseline, it is effect. Otherwise, this is toxicity. Okay. Now come to the other ECG. This is AVR. Baseline is here. Baseline is here. This is S. So it is normal ECG or abnormal ECG in the AVR?
Here, is it?
Is it
It's not
normal?
normal.
Is it normal or abnormal?
Abnormal.
Abnormal, because the all waves will be down. But here up, so it is one abnormal.
Yes.
Second abnormality is, you see in the S and there is no P wave, immediately go to the next lead. Immediately go to the QRS complex. This is the R. From the S, directly going to the R. Right? What about the QRS here? It is wide or narrow? This is wide. Wide R. Tall R, wide R. Both are abnormal. Wide R is abnormal itself, and the tall R in the AVR is abnormal. Plus, if you see that in the R, there was another R, a little fluctuation. It is called R prime. Okay, it is called R prime. That means RR, double R here. In which drug we may find it? This is tricyclic antidepressant. Can you give one name of the tricyclic antidepressant commonly we are prescribing? Can anyone say name of a drug? TCA? Anyone? Dr. Saida, Dr. Zainab also. Amitriptyline.
Exactly.
Amitriptyline, the mostly used drug, amitriptyline. So this toxicity can be visible in the AVR, R wave, you see in the AVR, secondary R wave, secondary R wave. And you see, this is a greater than 3 millimeter height. These are the characteristics. Now look at the bottom picture. You see, this is another R, secondary R. Go up, again another R. Very wide QRS. There is R is wide also here. Right? This picture is from your common textbook. So this appearance is TCA toxicity. TCA toxicity. So this is the drug effect. Can you identify the same picture near about here? Whenever you get the wide QRS, look at, there may be ventricular tachycardia also by the amitriptyline, VT. So itself ventricular complexes are wide. These are basic informations. In the wide QRS, if you look at the AVR, AVR is tall? Please answer, Dr. Rafia. AVR is tall, above the baseline or not?
R stall.
Yes, tall. So if it is tall, wide QRS, more likely this is amitriptyline toxicity. And you know about the drug history of the patient so that you can make a decision. These ECG possibly due to TCA toxicity, that means overdose or toxicity. There is amitriptyline, for example. So look at the QRS. So this is another non-cardiac, though effect happened to the heart. Cause is not heart disease directly. Now come to hypothermia. What about the QRS in the lead one? Is it normal?
No.
No. What is the abnormality you are observing? Is it wide QRS?
Yes.
Is it RR pattern? Is it RR pattern? That is a double R. Double peak is there. So is it RR?
Yes, sir.
Yes. This is one. So this is wide. If you look at the left-sided one, if you come to the right-sided one in the V1, this is not RR, but is it wide?
Wide.
Now come to the features of hypothermia in the ECG. Presenting sinus rhythm, normal axis, characteristic diffuse J point with R prime. It is a, you see, this is a R. It seems to be RR, but you see, this is the junction of the ST segment and R. This is the J point. So elevated J point, but here again secondary wave. Again it is secondary wave. It is called totally Osborne wave. Osborne. Look at down. So if any patient have the cold, exposure to the cold, and there are many cardiovascular changes, if you make an ECG, you may see this Osborne wave. But you may see different types of ECG changes also, different arrhythmia also due to the hypothermia. Now look at the ECG. You see, for the shivering, there are many fluctuation of the baseline in the cold. But these are not Osborne wave. Osborne wave will be here. You see here, J wave or Osborne wave. One is the J point, another is the wave. So it is called the Osborne wave at the arrow tip here. This is the Osborne wave, but the baseline fluctuation is due to the shivering. It is the artifact. So this is the hypothermia common ECG. Possibly you have seen in your undergraduate life also. So ECG features of the hypothermia, detail, the main points are given down. Even patient can have atrial fibrillation. Doctor, Be curious. It seems to be atrial fibrillation, fluctuation of the baseline, right? What do you think? Why only Dr. Rafia? Why not other colleague? Dr. Saida, if possible, can you talk to us? Or Dr. Khalid? You see, always we see that in the atrial fibrillation, there is a fluctuation of the baseline. But could it be actually atrial fibrillation in this lead? We have to look at the RR, rhythm. What will be the rhythm of atrial fibrillation? Regular or irregular?
Irregularly irregular.
Basically, irregularly irregular. Is it irregularly irregular in the RR here, where I am focusing?
Yes, sir.
We have to count the smallest square. 10 plus a little more. So here also 10 plus little more. Here also 10 plus little more. 10 plus little more. So there is no irregularity. So if it is not irregularity, it is not the atrial fibrillation. Rather, this is shivering effect. If you look up also. Clear now? So in the same patient of the hypothermia, patient may have artificial problem in the ECG, or patient may have a genuine atrial fibrillation. So basically, atrial fibrillation definition depends upon the irregularity of the complex, not the P wave fluctuation. If you go through our ECG class again in the YouTube, you can have the detail there in arrhythmia class, arrhythmia session. Now, some pulmonary, the ECG, the features of the pulmonary embolism. Though this is very well known, S1Q3T3, it is a mnemonic. S wave in the lead 1, Q wave in the lead 2, and T wave in the lead 3. That means changes in the S1 in the lead 1, changes of Q wave in the lead 2, and changes of T wave in the lead 3. 1, 2, 3. So look at 1, 2, 3. So what changes? In the lead 1, what abnormality we are looking there? Abnormality of the S wave. Here. Deep S wave, right? Deep S wave. Okay. What about Q3? Sorry, not 1, 2, 3, 1 and 3. 2 lead we have to consider. In the lead 3, we are expecting 2 changes. One changes in the Q wave, another changes in the T wave. What are changes here? Dr. Saida? About the Q, this is normal or abnormal? It is abnormal. It is a pathological Q. Pathological Q means the deep Q. So, so if I go back, deep S in the lead 1, but deep Q in the lead 3. In addition, T wave inversion in the lead 3. This is very typical picture, but not common ECG appearance in the pulmonary embolism. But is it traditionally we remember it. S1, Q3, T3, T3. Okay. But there are some other features also. Right bundle branch block. Right bundle branch block. How to say? In the lead 1, there will be wide. You see, these are the 5 millimeter square each box. So if you start from this there, RSR, right? It is called the M pattern. RSR, very big. It is near about 8 or 9 millimeter square. So this is wide. Okay. And V1, you see R is tall. Okay. And opposite, we will find wide S. That is called slurring of the S wave. It is the right bundle branch block. So you can go through again the detailed ECG lecture in the conduction problem, ECG discussion to see the bundle branch. So pseudo infarction pattern, Q waves in lead 3. So it seems to be infarction. In which lead? You see how fantastic it is? Lead 3. Clear, doctor? Is it right? Dr. Saida was talking to me. It's very interesting information I like to share here. In the lead 3, there is a pathological cue. To comment, this is inferior myocardial infarction. Usually we go to the AVF. Can you look at the AVF? Is there also pathological cue? Dr. Saida?
Yes, sir.
But we are telling this is pulmonary. We are telling
Embolism.
this is embolism. So is it embolism? Embolism patient will have the chest pain. MI patient also will have the chest pain. And the ECG changes are similar. So thing will be very confusing. Isn't it?
Yes.
So which other test we need to do now to be sure about? Definitely MI diagnosis depend on enzyme changes. Okay?
Yes, sir.
Troponin I. Troponin I. Again, there is some other confusion. If pulmonary infarction, that means, sorry, not infarction, pulmonary embolism causes pressure over the right ventricle, there will be increased demand of the right ventricle. And there is again loss of muscle in the right ventricle, and it increase the troponin I also. Thing will be very, very confusing at that time. That means pulmonary embolism associated with right ventricular ischemia or infarction. Anyway, I told you initially also, it may be a complicated topic today. I will not go detail there. But remember, in the pulmonary embolism, these changes can happen. The pathological cue may be in the 3 and the AVF also. But the typical picture is S1, Q3, T3.
T3.
T3. And to understand the better for this pulmonary embolism, there may be features of the right ventricular hypertrophy as well in the ECG. That means the right ventricular load. Now come there again, pulmonary embolism ECG. You see S1, Q3, T3. In which lead? 1 and 3. So how to remember 1 and 3, doctor? I think all of you of different country you understand. Unlucky. Unlucky which one? 7 or 13?
13.
13. So unlucky 13. That means lead 1 and lead 3. So patient is unlucky. ECG is unlucky. Doctor also unlucky. Why? Sometimes this cue will confuse the doctor. It is myocardial infarction or pulmonary embolism. So all the story of unlucky is here. Okay, now if you are AKT examinee, I think this simple thing will be apparent in your exam. Simple thing, not very complicated. So don't be serious too much to learn the detail of ECG for your initial learning. And pulmonary embolism is associated with the pulmonary hypertension due to the pressure. So again, you see features of the right atrial enlargement, features of the right ventricular hypertrophy as well. So they have given the mark here. Clinically, who can say pulmonary hypertension feature? Clinical after examination of the precordium. Please, can you say in the palpation, what feature we get in pulmonary hypertension? Palpable P2 in clinical examination, right? Palpable P2 or loud P2 of second heart sound in the auscultation. And left, what is that? Heave, left ventricular, left parasternal, not left ventricular heave, actually left parasternal heave due to the right ventricular hypertrophy. So these are the clinical features of the pulmonary hypertension. But ECG feature is like that. I think it is easy to understand. As there is a pressure effect to the right ventricle, subsequently pressure effect to the right atrium. So in the ECG, we will get features of right atrial overload or right atrial enlargement and features of the right ventricular hypertrophy. And you know the right atrial enlargement means P pulmonale. P pulmonale is marked here by the yellow color. So these are the features of pulmonary arterial hypertension. And what is showing? This ECG is not much clear though. This is the similar feature, but all feature may not be there. Suppose right bundle branch block. 1, 2, 3. AVR, AVL, ABF, and V1. So in the V1, you see tall R. Tall R indicate right axis deviation, or rather to say right bundle branch. If block is there, actually there will be the wide QRS. There is no wide QRS. But is the right axis deviation, we can say, if you see the lead 1 and lead 3, or lead 1 and the AVF. I think we can talk another day detail. AVF is here. AVA is much positive, but lead 1 is down. But you see P is up. It is not lead displacement. The initial first ECG, you can remember, in the lead displacement technical problem, P wave is down, but here P wave is up. So it is not the displacement. It is typically negative deflection in the lead 1, but positive deflection in the ABF. So more likely this is right axis deviation, and right axis deviation can happen in the right bundle branch block, right ventricular hypertrophy. Okay. And right atrial distension, sorry, right atrial deviation, right axis deviation. There may be atrial enlargement also. If there, it may not be there also. So pulmonary hypertension ECG as such, that is the right-sided changes of ECG. Okay. Now pulmonary diseases, not pulmonary hypertension, pulmonary diseases, that means the lung disease. So usually common feature is P pulmonale in the COPD. That is the right atrial enlargement. P pulmonale is P wave is taller than usual. You see, look at the lead 2, P wave is taller. Pick here later. It's a semi-diagrammatic for better understanding. P wave is, you see, more than 5 millimeters. So typically, confidently we can say P is taller. So this is P pulmonale, P pulmonale. So as well as we can get other features of the right ventricular hypertrophy. You know the core pulmonale diagnosis. This is the lung disease causing the right heart failure. So pressure to the right heart. So after the pressure, what is expected ECG changes, you will get there. So these are the mention in this slide, particularly visible in lead 2, 3, AVR, ABF, and V1 and V2. So many leads showing this picture. And another P wave issue, doctor, though it is not mentioned here, it is called multifocal atrial tachycardia, MAT, multifocal atrial tachycardia. It is also a common feature in COPD. COPD. This is the effect on the heart, but disease in the lung. Now, in the, you see, ECG changes, P pulmonale. Where is the P pulmonale? And you see characteristics of the P pulmonale mean mentioned there. This is the description. ECG changes in chronic lung disease. Chronic lung hyperinflation means COPD, emphysema. In these COPD patient, many changes we are getting. But usually in COPD patient, we are not doing ECG. But if patient have the chest pain, COPD patient also a smoker, ischemic heart disease patient also a smoker. At that time, we need to do ECG. And if you don't know the ECG change in COPD, we will say confusingly, we will confuse about heart disease and the lung disease. There is an impact in the heart though, but primary disease in the lung. For that, we need to know about different pattern of ECG changes. Now the great issues of your exam, very common, very important, is the electrolyte changes. First of all, hyperkalemia. After this, we hope we can conclude today's class after a few minutes. Be serious and attentive with each and every second, please. Hyperkalemia, what you are getting there? Dr. Saida, what you are getting?
Sir, tall T waves, 10
Yes, tented. So TT, TT, T tent, TT, T wave tent, right? Table tennis. So T is much up. And potassium also much up. Easy to remember. If tented, tall, T. So this is tall potassium, rather to say tall potassium. That means potassium is high. This is one characteristic feature. Okay. And the QRS is widened. Definitely widened. More than 3 small s square is widened. And subsequently, these widen will be more widened that it will be a straight line later on. Let's see now further. In the ECG, 12 lead ECG, I think we can now easily diagnose hyperkalemia. Spike appearance. Dr. Rafia. Dr. Rafia.
Yes, sir.
When we say T is tall, the length of T wave, when we say T is tall, anyone can say, please answer my question. When we say that T is tall, then normal. Who can say? No one. Oh, sad. So again, doctor, my humble request, go to the basic ECG, right? Dr. Saida?
No idea, sir. 4
No
millimeters,
idea.
more than 4.
Oh,
Because
sad,
I didn't
Dr.
watch your
Saida.
ECG.
Oh, but you know you forgot. Otherwise, how can you say tall T? There is a word in ECG, right? We
Yes,
forgot. Because we are not dealing. We are not discussing each other. 5 and 10. Remember, if it is in the chest
Five.
lead, it is more than 10. Okay? If it is the
Yes, sir.
limb lead, it is more than 5. Usually. Okay?
Yes, sir.
Than 5. Not all. Suppose if the limb lead you see here, if it is the baseline, it is definitely more than 5. Isn't it? Another
sir.
way, another trick is look at the R wave and T wave. Which is taller? Which is taller?
T wave is
Rafia, be
taller.
serious. Rafia, you don't know or you forgot, is very sad. Which is taller? R taller or T taller?
T wave is taller.
Taller. Without counting also, by a general look, you can have an idea. T is taller means there may be chance of hyperkalemia. Peaked, usually in the peaked. You understand peaked, that means a pointed. So this is hyperkalemia. Now, Dr. Rafia raised the hand for what?
Sir, can you please describe the picture again, please? Because there is some network issue here.
Okay. You see, this is the T wave. This is the R wave. Which is taller?
R wave.
Oh, look at again. This is R wave. This is T wave. You are confused.
T wave, sir.
That
T wave,
means
sir.
T wave that much taller. You are confused that it may be R. This is T. So it is hyperkalemia. Okay?
Okay.
Hyperkalemia. Now come to the hypokalemia. Just think T wave is down. T wave down. So potassium also down. I am telling simple tips. I will tell furthermore. Simple tips is potassium down, T wave is down.
Down.
Okay, one thing. Second thing, there are some other features of hypokalemia. It is ST segment depression. Okay. And the appearance of U wave. Appearance of U wave. But now, if you look at, if this is T, ST segment, there is a wave pattern. Definitely this is T. Clear? Be with
Yes.
me again.
Yes.
This is T. If you cannot identify this is T, you may wrongly say that this is T. Okay.
Yes, sir.
So we have to be able to say which one is T. Otherwise, we may not identify the U wave. Okay. Now come to the next slide. Cannot remove it. Sorry. Why? Yes, now gone. Look at now. T may not be down always, but T will be flattening. What is the T flattening or T down? Okay. But ST segment will be down. But if there is appearance of U wave, you may be almost certain that this is hypokalemia. If you look at the right-sided lead, this is the T wave, right? Doctor?
Yes.
So it
Yes,
is not down. It is not down. You may not get all the features in the same time. It is true. It is not down, but there is side by side one, another T-like wave. It is not P wave of the next ECG. It is in between, right?
Yes.
Just closer to the T wave, similar positive reflection, but height is usually less. This is the U wave, remember. So wherever the U wave, there is hypokalemia. Kalemia. This is very exam ECG, doctor. Please, please, all of you try to remember. Must. And in the ward also, until you get the electrolyte result from the laboratory, within 5 minutes, you can say that this is hypokalemia. If usually ECG changes happen in severe hypokalemia. And severe hypokalemia can cause arrhythmia of the heart, can cause death of the patient. For that, a doctor, primary doctor should know about. So a diagrammatic representation to differentiate hypokalemia and hyperkalemia. Just if you try to compare T wave, in the hyperkalemia, T is up, peaked. But in the hypokalemia, usually, I'm telling the word, usually T will be down, but may not be always. So you just pull up and pull down. So pull up, potassium up, pull down, potassium down. Hyperkalemia, hypokalemia. In addition, ST segment also down here. ST segment down here. Okay, so this again, sorry, a little not very clear slide though. There are some differentiating points of ECG. Again, I will show you in our common medicine book. This is normal ECG, moderate hypokalemia, moderate hyperkalemia. You just compare there fast. Okay. Flattened T wave, initial features. Flattened T wave and peak T wave. This is the gross difference. But it may be normal to you, right? For the hypokalemia. But whenever you get U wave, then you will be confident it is hypokalemia. That is, U wave appear in severe hypokalemia. And there is ST segment depression also. It is true. But you come down in severe hyperkalemia, where is the peaked T, doctor? Is there any peak T?
No.
No. So peak T is not features of severe hyperkalemia. Peaked T is feature of moderate hyperkalemia. But if it's severe, actually how we learn, how much I will be able to make you understand in different cultures, colleague are here. If this is a rope, you understand, Dr. Saida, your background from which country?
India, sir.
Oh, India, you are nearer. But some Arab colleague might be here. Rope, you understand rope?
Yes, sir.
Rope. So this one end of the rope, another end of the rope is string, string. Just you pull apart, understand? You just pull this one according to this direction and this one according to this direction. the ECG appearance will be gradually as such, right?
Yes.
Only QRS is left.
No, it will be ultimately flat line. And life will be flat. Ventricular fibrillation. That is, sorry, better to say not fibrillation, cardiac asystole. No electrical activity will be there. If hyperkalemia is increasingly high up, that means ECG will be a straight line. It means this moderate ECG, just you imagine that you are pulling apart. Then ECG will be sinuous. It is called sine, S type, S. It is called sinuous line. Sinuous line. It is the hyperkalemia feature. Can you understand, Dr. Sayeda?
Yes, sir.
Good. And in the right side, it is given different value of the potassium with type of ECG. You see, if the potassium more than 8, there is a sine wave that I described to you, sine wave. And ventricular arrhythmia followed by asystole. Arrhythmia may be ventricular tachycardia, ventricular fibrillation, finally asystole, a straight line. Okay. And if you again pull the rope, you see loss of the P wave. There will be no P wave. So this, it is a collection, doctor. I think it will be useful for you if you make a snapshot here. You may not get this combined information anywhere. So to compare the hyper and hypo, we will try to compare first with the T wave, flat T wave and tall T wave, flat T wave, tall T wave. Finally, these are the complication of the electrolyte disturbance. This is the most important non-cardiac ECG for you. Remember it. Those I discussed some other topics. Okay. Just few minutes, doctor. I will not discuss more. Now come to the other electrolyte problems. Sorry. These are the hyperkalemia, hypokalemia. Make a snapshot. Different ECG changes are described there. And going further, come to the other electrolyte, calcium and magnesium. These are the changes of calcium, magnesium. A, B, C, D. There are 6 changes in 6 conditions. Already we described hypokalemia, hyperkalemia. That is the C and D. Already we described C and D. What is A, B? Hypocalcemia, hypercalcemia. In the A, look at prolonged ST, right? Prolonged ST segment. Indirectly, it means prolonged QT. Clear now? Prolonged QT. Isn't that it? Prolonged
Yes,
ST, so prolonged QT is the hypocalcemia. And reverse is true for the hypercalcemia is short QT. Only these two remember enough. Prolonged QT, short QT. Hypocalcemia, hypercalcemia. So there may be complication, torsa dipoma or other features. Sorry. I am again will be going back to the same slide. Now come to the magnesium. Magnesium very puzzling. Very puzzling in a sense. You see, hypo and hyper have the similar features. Tall T wave, depressed ST segment, one features, but there is no comment about the ST segment. PR prolongation, there is PR prolongation. Wide QRS. So what is the differentiating point? Differentiating point could be here, depressed ST segment, and in the hypermagnesium, a flat P wave. But do you know, hypomagnesemia may be associated with hypokalemia. Do you know? Yes. Then ECG will be mixed up. Some ECG feature like hypokalemia, some ECG feature like hypomagnesemia. For that, hypomagnesemia, we may not get enough help from the ECG, in my sense. And in general, actually, electrolyte disturbance is diagnosed by the blood test. But in ECG can help us, assist us for understanding. So these are 6 electrolyte problem. There are some different appearance of ECG. Okay. And at the end, look at the 12 lead ECG for the hypocalcemia. 12 lead What is the typical feature? Long QT. It is called the corrected QT, long QT here. And hypocalcemia, short QT. It seems to be short, doctor. You see, T is very closer to the QRS complex. Without counting also, we can say it is short QT interval. So there is a value for the male and female. Anyway, basic thing is short QT. So QT is for calcium. QT is calcium. Now the magnesium ECG, what we say? Flat T. Another is what? Depressed
T waves.
ST. Hypomagnesemia is depressed ST. Can you identify depressed ST? I'm going back for you. Sorry, doctor. Many noise. Is it ST is depressed? ST segment? What do you think? ST segment depressed or not?
Yes.
Yes.
Yes,
So
sir.
so it is features of hypomagnesemia. But will I not be confused with ischemic heart disease here, doctor? Right? Understand? Doctor,
Yes.
very simple knowledge.
Yes.
ST segment depression indicate ischemic heart disease.
Yes, sir.
Angina.
Yes, sir.
Angina. But in the coronary, if it is coronary artery disease, the change will happen in according to the territory. Right? Territory means 2-3 ABF or 1 AVL accordingly. Okay? But again, angina can happen in hypertrophic cardiomyopathy, but not by the coronary artery. In this situation, there is a diffuse ST changes. It will not indicate coronary artery like ECG change. But hypomagnesemia also causes this type. Hypomagnesemia is a generalized feature, right? It is a biochemical feature. So it will not follow coronary artery distribution. So hypomagnesemia actually confuses us. But as a clinician, if patient have diabetes, if patient have hypertension, if patient have dyslipidemia, we will say this ECG is ischemic ECG. But to exclude the electrolyte disturbance, I will advise for magnesium level in the blood. It will be our clinician's decision. Similarly, hypermagnesemia. In some hypermagnesemia, patient will have long QT. The QT may be in hypomagnesemia. Hypomagnesemia can cause, it is called, the electrical problem is torsa de Points. Torsa de Points. So the QT changes actually will not be helpful. Rather, QT change will be helpful in the differentiation of the hypercalcemia and hypocalcemia. Okay, so my request, don't remember these QT changes in the magnesium issue. And I commented before also, ECG changes will be confusing. So magnesium issue, to be confident, rather advise blood test. Because magnesium may be associated with the hypokalemia also, with low potassium. So there may be mixture of ECG changes for the magnesium. In clinical practice, it is important for the management of hypokalemia is that if patient have hypomagnesemia, hypokalemia cannot be corrected. This is the tips for management. For that, we have to check magnesium level as well to correct high potassium. So you have to give the treatment of potassium as well as the magnesium both together. So these are the clinical informations I like to attach with my discussion today. And at best of my capability, actually, I have shown to you the ECG changes in extracardiac issues just to remember in future life, so that you should not feel foolish by yourself that, oh my God, I didn't hear ever in my life. Okay, doctor. So with this few words, I like to conclude. You see, hypomagnesemia causes prolonged QT, but somewhere I have seen the prolonged other issues also. So I like to request you to modify my messages. So these are in a nutshell of electrolyte disturbance in ECG, and this picture can help you to remember. So again, if you like to focus for the exam only, these 4 changes. potassium and calcium. Okay, so things are very easy now for you. Potassium change and calcium changes in the ECG. Hopefully easier for you. Okay, Dr. Saida.
Yes, sir.
So I discussed a little advanced level though before. Now come to very simple summary. Thank you very much, doctor. Thank you. Thank you.
Thank you, sir.